Hello, my name is Richard Warren and I work in Vancouver with the Division of Plastic Surgery at the University of British Columbia. The paper I'm reviewing for you is written by one of the legends of Brazilian plastic surgery, Dr. Claudio Cardoso de Castro. It's entitled Updating Concepts on Neck Lift and the Lower Third of the Face, and it's based on 1,500 facelift patients who were treated between 1973 and 2009, a period of 36 years. The purpose of the paper is to present the author's lifetime experience and to offer his conclusions regarding the appropriate treatment of the lower third of the face and neck. This is a timely paper because the treatment of the lower third of the face and the neck is actively debated in our literature. At one end of the spectrum is the author, Dr. de Castro, who in 1980 described the anatomical variations in the anterior platysma. At the time, he felt that the correct way to treat the aging neck was to open the neck and plicate anterior platysmal edges together. Now, 32 years later, he hasn't changed his mind one bit. In 80% of this series, a submental approach was used, fat was removed, and the submental plication of the platysmal bands was done. Now, in recent years, a number of other approaches have been popularized to deal with this part of the anatomy. For example, in 2002, Thenard and his colleagues in Belgium published a series of 88 max lifts in which long suture loops were used to suspend the platysma and lower third of the face to fixed deep temporal fascia. Almost all of the necks were treated with closed submental liposuction. Later, Labbé from France published his concept of suspending the posterior platysma in a vertical direction, fixating it to fascia overlying the parotid gland. His concept was that the skin of the neck and the platysma should be treated as a unit, and by elevating it vertically, a submental dissection can be avoided. So as things stand now, there is really no consensus about the best way to treat a neck. Of course, the difference with this paper is that the author has the advantage of 40 years of experience with personal patient follow-up. Interestingly, despite this extensive experience, he chooses not to treat digastric muscles or ptotic submandibular glands because he is concerned about the surgical morbidity. As for the cheek area, the author always does something to the superficial fat and the SMAS. Although this is not documented with case numbers, he tells us that in thin faces he prefers plication, and in all other cases he does a SMASectomy or an extended SMAS approach. This type of customization of cheek lifting is quite common with most advanced facelift techniques. Unfortunately, in this series, there was no attempt to quantify the results as to longevity, patient satisfaction, or quality. However, complications are reviewed and there are remarkably few of them. There was one death, although we are not told what caused it. There were no cases of facial nerve palsy that were permanent, and there is a remarkably low hematoma rate, only 4 cases out of 1,500 which required reoperation, making this one of the lowest reported incidences of hematomas in the world at 0.25%. This large series adds to our body of knowledge in the field of facial rejuvenation surgery. It's a highly personal review of an approach that's been used consistently for a long period of time. And while this paper may not change the mind of surgeons who use other methods, it will give comfort to those who prefer this approach. So in closing, I would like to thank the author for assembling a lifetime experience of facelifts and to share with us his advice and his conclusions.